You can do any specialty at any time, simultaneously, whenever you want. There's so much flexibility in the PA profession.
So, guys, I am hosting and I guess the guest, and doing both the eShadowing presentation and moderating the chat. So we're still, we've been doing this since November, and we've just had about every specialty. I think the only specialty we haven't had is endocrinology and pediatrics. Endocrinology, we actually did do hematology, endocrinology, and pediatrics. So we've gone through just about every specialty. So we're going to start, of course, repeating a lot of specialties, but I want to bring on more guests, different guests from different specialties. So that's what we're working on now. But we will have a guest next week and the week later. But for tonight's session, I'm going to be doing an emergency medicine session. And of course, answering all your questions, or answering as many questions as I can about emergency medicine or the PA field in general. And of course, like PA applications as far as I understand. And so it's going to be a fun session as usual. And we'll get started. I'm first going to start off by answering any questions that you may have as it relates to applications, as I said, in emergency medicine. And then I'll tell some stories if you guys want to hear some emergency medicine stories, and then go on to a case study. I do have a case study presentation. I think it'll be fun. So we're going to hop right into it. Today is emergency medicine. Anytime that I present, since I'm an ERPA, it will be emergency medicine focused, or it's a little bit of urgent care. So I am emergency medicine. Anytime you see me, Rodeline, present, typically it'll be revolved around the ER. And you'll all still get credit for this session. All eShadowing sessions, whether I present or we have a guest, whatever it is, even if it's a guest from a PA school, like a professor or an admissions person, whatever it is, you'll get credit for it, because you're still learning about the PA field, no matter what or who's presenting.
Okay, so somebody asked, the first question that I saw, you guys will probably have to repeat your questions because the chat reloaded, but the first questions that I saw was if you can work in another specialty while doing emergency medicine, and the answer is absolutely yes. You can do any specialty that you like simultaneously. You can, we actually have there's a PA at my job that does emergency medicine, and she does OBGYN, so she'll literally do like 24 hours, so she'll work in the ER like a day shift, and then like I'll call the OBPA or OB consult, and then she'll come down. I'm like, dang girl, like you're doing a 24-hour shift. So yeah, you can do any specialty at any time, simultaneously, whenever you want. There's so much flexibility in the PA profession. It is very hard to me, it was hard to get into emergency medicine straight out of PA school. So if you are really interested in becoming an ERPA, try to get a rotation in the area that you want to practice. So if you want to practice back at home, and you're from like Canada, okay, let's not use Canada, New York, and you're in PA school in Massachusetts, try to get a rotation in New York, close to home, exactly where you want to work, so you can easily get into that practice, or so you can show yourself off and have a better chance of getting a job straight out of school. Because it's really hard without that experience. A lot of ER jobs want at least 1 year's experience just as a PA, not necessarily in the ER, but just as a PA. I mean, it can depend on where you work, because there have been classmates that were able to get a job straight out of school. But as far as Florida or like highly saturated areas, very popular areas, it will be a lot harder. It was hard for me. If you all don't know my story, I had to actually work like random jobs my first year as a PA before I can get into the ER. And I didn't even get into the ER in South Florida. I actually got into the ER in Georgia, and it was a rural ER at that. It was like a very small. Well, I practiced at 2 different locations under the same hospital system, but my main area was a very small ER. It was like a 9-bed ER. I got really good training, but yeah, this is just to say that it can be difficult getting in straight out of school. Yes, eShadowing is free. Yes, the urgent care is a great place to get patient care hours. Any field, job, anywhere you can go where you'll be able to communicate with patients, to have direct hands-on, like touch the patient, get to know patients, see how healthcare is day to day. That is a good place for healthcare experience. There's no specific, place to go and get your hours or your patient care hours. As long as you're able to communicate, see, touch patients, that's what they want for patient care hours. So urgent care, private practices, hospitals, nursing homes, all of that, even home health, all of that is good. ARCPA is the accrediting body. PAC is the certification. Somebody said, what's the difference between ARCPA and versus PAC? ARCPA is like the accrediting body. PAC is the title that you have once you pass your boards, physician assistant certified. Do you know any PAs working as a firefighter? I do not know any PAs that currently work as a firefighter, but usually firefighters get an EMT certification, I believe, and that's good experience for PA school. As far as online PA programs, I'm not a big fan of online schools just because nothing can replace that classroom experience. And just, of course, communicating with your classmates, getting to know your classmates, building that relationship, because you guys are going to, need each other for a lot of things. And you guys are going to practice OSCEs and physical exams on each other. I know they do different things with online, like you'll be able to still go into school and, I'm sure they have their way of making it work. But I just feel like nothing can really replace that, classroom experience, even though classroom right now is basically online too. So, I mean, whatever floats your boat, as long as you're confident going out of school, you're able to pass your pants, you're able to be a proficient and successful PA, that's all that matters. What was your experience as like a new graduate PA? My email is, I sent my email, Rodeline, my first and last name @medassembly.com. Oh, there's a lot of questions. I'm so sorry, guys. You guys have a lot of questions. I like that. Did you run codes in the 9-bed ER? I actually did not, but there's a very well chance that I could have because it was such a small ER. I learned a lot working in that ER too because it was just myself and a doctor at any given time. And I didn't run any codes, but if it did become busy and the doctor had a code and another code came in, I was going to have to do it. And child, good thing that didn't happen because I was like a new grad. So, but the nurse practitioner that was before me, that worked there before me, did have to run codes. But she worked there a longer time than I did. I did 1 year because it was, like I said, it was a very rural area. I'm more of a, I'm not too much of a city girl, but I like the more city type of vibe. It was in Perry, Georgia, the middle of nowhere. What was the hardest part about PA school? The hardest part about PA school was, I don't know. That's a very touchy personal question for me because it was the hardest part it was difficult adjusting to PA school and, having to learn how to really study and studying not necessarily just to pass, but to really know what you're learning, to really know and understand because you're going to have to apply this in your day-to-day job or career. So that was a hard part. But for me, just from my personal experience, and I guess you guys, learning more about me on a deeper level, it was just, I was like one of the only minorities in my program, the only Black woman in my program. So it was very difficult adjusting to that, just being an only. So that was the hardest part for me. I don't want to get too much into that, but that was very hard for me, difficult to maneuver. Okay, I'm just trying to get through the questions, answer them. Yes, I always say medical scribe is great experience, but a lot of schools don't recognize that, or certain schools don't recognize that as healthcare or patient care hours, because you're not directly touching the patient or communicating with the patient. You're kind of in the background, kind of doing as the physician or provider does or tells you, but it's like one of the best ways to get experience, honestly. So it's really dependent on the school. I would, get in contact with the schools that you're interested in. My name is Rodeline Joseph. Somebody asked me my name. What are tips for studying and being in PA school? Okay, so I'm really excited for this time period because CASPA is going to open in a few weeks, I think in 2 weeks, towards mid to late April, if I'm not wrong. CASPA is going to open soon, which means that it's going to be time for application notifications, like being notified about supplemental applications, being notified about interviews, getting back admission acceptances. So I'm really excited for all of you. I am sure that all 315 of you that are tuned in will get into PA school. I have faith in all of you and so happy and excited for your journey, whether you're applying to school this cycle or in a few years from now or whatever it may be. So once you get in, like I said, you have to unlearn the way that you learn to study. Us being like, I'm sure a lot of you are perfectionists, where you want straight A's, you're kind of fighting for a GPA, maintaining a certain GPA, being great at this, great at that, when that's not really what's, important. You have to, remember that this is real life. This is no longer, you graduate high school, then you go to college, or, constantly, learning or going after a degree. You're not going after a degree per se. You're going for your career. You're going to treat patients. You're going to be saving lives. So don't focus on learning just to maintain an A or B. Learn to really learn. If you get a C, but you know what that is, you can, proficiently explain to somebody what type 2 diabetes is and how to treat a patient with type 2 diabetes. That is what is important. It's not the fact that you got a C and somebody else got an A. So that's one of the biggest things for, us that we have to understand and do. So you have to study to really understand the material, not study just to get an A or B, or say that you have a 3.9 or that you're going to graduate magna cum laude from PA school. Don't nobody care about all that. Not one person that hires you is going to ask you, well, as far as I know, and if they do ask you that, why would you even want to work with them? They're not going to ask you, what was your GPA in PA school? What did you make on your anatomy exam? Did you pass it with an A+? No, because that's not what's important. What's important is knowing that you can treat a patient. Okay, so remember that. Remember that, if you fail an exam, it's okay. Learn how to study. I say study everything at least 3 times. How I did it was I would go through the PowerPoints. I barely read the books. I would go through the PowerPoint. Sometimes if I needed to, read the books, I would read the books. I really believe in repetition. If you see, I believe that if the rules of 3, so if you see something at least 3 times, it'll really start to stick to you and really understand it. So I would try to read it 3 times, go over it, write it down. I also believe in really writing things down because that also builds that memory and understanding. So I would do that, and then I would go through Quizlets. Listen, I have my Quizlets for PA school. I don't know if, medicine is medicine. It's always going to be it's always changing, but for the most part, diabetes, the way we understand diabetes is, 5 years ago when I was in PA school is basically the same now. So if you guys want access to my Quizlet, I can give it to you. I have so many Quizlet flashcards, y'all. That's all I did. I would Friday, I would go through PowerPoints. Saturday, I would go through everything. And then Saturday and Sunday, I would start working on my Quizlets. And then Sunday, I would spend the whole day going through my Quizlets. I would go through Quizlets at least 3 times. So, and then I would start to understand it by going through it so many times. So I can give you guys access to my Quizlet. Actually, once the session ends, I will post it because that means I'd have to search the link and all of that. So I'll send you guys my Quizlet. It has like I started Quizlets. I didn't do it all throughout PA school. I started it in like my second or third semester in PA school, but I was a Quizlet queen, y'all. So Quizlets really helped me writing things down. Of course, study guides. You'll get study guides from your classmates, from past classes as well. So that also really helps. YouTube, Khan Academy came through in explaining things. The way they broke things down and explained things. Yes, you guys, Khan Academy. I know there's a lot more like YouTube pages and different people on YouTube, but Khan Academy was like my favorite. Khan Academy and somebody else. I have a list of all these things that helped me. I can send it to you guys in an email. But yeah, I'll post my Quizlet on, MedSembly, because on my MedSembly page at MedSembly, you can like swipe up it takes you directly to that link. So I'll post it on MedSembly. So I'll post the Quizlet on MedSembly so everybody can access it. But after this session ends, I'll also post the link because I have to go look for it. So I'll also post it then. So I guess YouTube, Quizlet. YouTube is Khan Academy especially helped me with anatomy, y'all. I was struggling in anatomy and physiology, but Khan Academy came through. That's all I have to say, Khan Academy. You're constantly going to study. There's not a how long before an exam. Somebody said, how long before an exam in PA school did you start studying? You're constantly studying for an exam. You have exams every single week. So it's not like you can say, oh, I'm going to start studying for this exam, then in this, like, you're just, like, the minute that they start that subject, you have to start studying because it's only a matter of time before you have a test on it. You have a test. You'll start say you start learning about diabetes or endocrinology on a Monday. By that next Monday, you'll have an exam, or that Friday, you'll have an exam on endocrinology. And on top of like an exam on physical diagnosis. So you have just multiple exams at once. So I can't even say, oh, when do you start studying for one thing? I just start the day of, I'm not gonna lie, I'm a little procrastinator even in PA school, which is not good. So I would really start studying, like, I would prioritize too. Like if I felt like I knew something well, then I would start later. Like physical diagnosis is kind of easy, learning how to do physicals and stuff. So I would like wait a day or two to go over that. As compared to med surge, or whatever they call it in PA school. As compared to that, I would start that earlier. But you're just constantly studying for everything at once. Yeah, you blink and there's an exam. There's a lot of questions. Okay, so we have about 10 minutes left before I go into the case study. I'm going to talk 5 more minutes about PA school and then another 5 minutes about the ER and then go into the case study. Yes, I'm going to send out my Quizlet. You guys are such overachievers because y'all not even in school yet. I guess you can just, bookmark it for when you do get in school. But I hope it helps you guys because I tried to make it like really good. Okay, so I can send you guys a link of people that I like to follow, all PAs that I like to follow, resources for PA school that I have that I like. I'll send out. If you guys want that, let me know. How am I going to get it to all of you? I don't know how I'm going to get it to all of you, but maybe on Instagram or something. I'll post it. I'll share it. I'll share the Google Drive. My best advice to get into PA school is to just be yourself. Outside of the stats, just be yourself, because once you get that interview, that's all it's about. I know you're going to be nervous. I know you're going to be, anxious, but just be yourself. You don't even have to discuss medicine during the interview. You don't have to discuss anything that's related to PA per se. They really just want to know who you are, because your stats are going to explain that, your GPA, your healthcare hours, all that's going to kind of tell them that, what a PA is, what entails in being in healthcare. So the next thing is knowing, okay, is this person morally sound? Can this person make sound decisions? Like I told one student, a question they asked me in the interview is something about, oh, if somebody was cheating on me, if a classmate was cheating on me and I caught them cheating on my paper, what would I do? How would I handle that? And that's just wanting to know about who you are and your moral and ethical, stance on life. So that's all I can really say, because there's not a perfect candidate. There's not a perfect student. None of us are perfect. So what one person is lacking in, another person is excelling in. So if a person has a 3.9 GPA, they may have no social skills. They may, bomb the interview. So don't look at, don't compare yourself to other people. Don't look at other people's stats. Find out what your strength is and shine. Okay, if your strength is the fact that you have an amazing blog, or you have this amazing story, something you conquered, shine in that. Take advantage of your strengths and show that off. My strength is my smile. That's all I did in my interview because I was so nervous. I'm just kidding, but I mean, that really is all I did. Okay. Chegg. I didn't really use Chegg in PA school. Magoosh, listen, these people need to make me their little ambassadors and whatever, because I'm really putting y'all on right now. Magoosh for GRE prep was the bomb. Listen, I don't do what I did. Don't do this at home. I literally studied Magoosh, crammed and studied in a week, and then I went to take the GRE. It's supposed to be a 6-week prep. I did it in a week, and then I went to take the GRE. But Magoosh is bomb. I don't know really much about Kaplan. I did Kaplan practice questions for my their book, but as far as a test prep, Magoosh, I tell everybody that, Magoosh, and I say 6 weeks of hard down, crack down studying for the GRE. I know some schools don't require the GRE, but most schools don't. I recommend you guys just take the GRE. Like I said, you want to optimize your chances of getting in. And if most schools require it, just take it. Somebody said, what is MedSembly? Okay, I'll take the time out to explain MedSembly. Okay, so being that just MedSembly is basically a startup that I founded to basically bring everybody in the medical field together and create a resourceful hub for those in the healthcare world, where I can bring, students and those that want to get in the in medicine in general together, and offer or facilitate that true networking with students, professionals, those that are already in healthcare, offer mentorship, offer resources. Basically what I'm doing now on a greater scale, to where it's not just pre-PA or PA students, but just everybody in healthcare. It's similar to, you can think of it as a LinkedIn for healthcare, but I really wanted to offer resources, really want to bridge that gap in healthcare, make sure that those that are coming into healthcare or preparing for a healthcare career get out there and be confident in what they're doing, have great mentors, create an area where you can just go on to a utopia, to where you can go on and be yourself, be able to vent, be able to talk to like-minded peers, and just make healthcare better for those that are in it. So that's what I'm working to create. And I'm working hard to create that. So look out for it. Okay. All right. What schools did you apply to PA school, and what were your stats? Okay. My stats, I don't really remember. I know I had at least 2,000 hours from when I worked as an LPN. I had about a little over 2,000 hours. I had 60 shadowing hours. My GPA was a 3.6 or 3.7 overall. I do not remember my science GPA. My GRE was a 151 and 153. I don't remember what I got a 151 and 153 in, but it totaled to 311. I know that I needed at least in the 50th percentile, and that's all I aim for. Let me see. I think where I was really able to stand out was my essay. And I say that all the time, like, make sure your essay like is just bomb. I think I had a really good essay and that helped me get into PA school. So I submitted my application August 31st. I felt like I submitted it kind of late. I submitted it August 31st. I heard back. I applied to 8 schools. At first, I was just going to apply to 4, but I let these forums get the best of me and feel like I wasn't worthy. And so I just applied to more schools because I was scared I wouldn't get in. So I applied to 4 in-state schools and 4 out-of-state schools. No, I applied to 12 schools, 4 in-state schools and 8 out-of-state schools. I know for sure I applied to 4 in-state schools because I really wanted to stay in Florida. I absolutely love the state of Florida. So I wanted to stay in Florida, but I wasn't sure of my chances of getting in. So the out-of-state schools were kind of cushioned. But I actually didn't interview in any out-of-state schools because I didn't have to. It was just in case I didn't get into in-state schools. My first interview was at Nova. It was actually my first in the school that I actually chose. But it was Nova Southeastern University in Fort Myers. That was the PA program that I went to. I applied to the Florida schools, University of Florida, Nova Southeastern University, Fort Myers, Nova Southeastern University, Orlando, and Barry University. I got into 3 out of 4 schools. UF waitlisted me. I heard back from Nova first. I applied August 31st, got a supplemental application like a week or 2 later, got an interview invite like the next week after that. I interviewed October 26th. It was a Friday. And then I got an acceptance that following Monday. I got a call. And the same thing was like, it was the case for all the schools. Like I interviewed and then like 2 or 3 days later, I got a call. So Nova Orlando, Nova Fort Myers, Nova in Barry, I got calls right away. And that's what I don't know if this is still the case, but if they like you, they'll call you right away. Yes, I had people read over my essay. I had friends. I had those that were already in PA school. Yeah, I had people like go slaughter my essay for me. How long did you study? Study for the GRE? I'm telling you guys, don't do like I did. I studied for the GRE literally a week. It's not like I just sat down and studied for a week. I had flashcards. I knew that my weakness was the vocabulary because math is math. So my weakness, I think, was the vocabulary. So I bought flashcards like earlier in the year, like months prior, and I would just kind of go through them like just passively, like take the flashcards everywhere I went and just go through the flashcards. I didn't really feel like studying. But as far as hardcore sit down, study, I think you need 6 weeks of that. But I did 1 week, which I don't recommend. I did take a gap year. The best to apply is May, June, July. May, June, July. If you have everything together, I wouldn't say to submit it like the same day that CASPA opens. Just cross your I's, dot your T's, make sure everything's perfect. Start, let me just get my charger. Sorry guys, I'm in my apartment. As you all know, I'm in New York right now, so I'm not in my house. Okay, so cross your T's, dot your I's, make sure everything's great. Have people go over your application, make sure everything's perfect before you submit it. So if you're ready to submit it and want to submit it the same day CASPA opens, great. But it's fine to wait until like June, May, July, anytime after, because you want a high chance of getting in. You want to optimize your chances. So that's why I say apply early. Somebody's please. What was your question? I'm sorry. I'm trying to, Mira. Can you ask your question again, Mira? If I don't answer your question, I promise I'm not ignoring you. I have a ton of questions. Mira, somebody asked, can you answer my question? If I don't answer your question, also just email me. I promise I'm not ignoring you guys. Advice for PA students with ADHD or autism. I've had accommodations throughout college. If you have if you suffer with ADHD or autism, I mean, it doesn't mean anything. It doesn't mean that you won't be able to get in or that, you're going to be, a more difficult applicant. You made it this far in life, obviously. So you definitely can always get into PA school and conquer PA school. Just have a bomb essay. Do this. Don't do anything different from anybody else as far as like, you know, your application, your essay. You're gonna have a bomb essay. You're gonna obviously talk about how you were able to come out on top despite, you know, certain hurdles you might have had in life. So shine in your essay, shine in the interview, and all PA schools will definitely be able to accommodate you. So I want you to just be more specific by what you mean by advice, like it's specific advice as far as like getting into PA school or when you're in PA school. No, they will definitely not judge you on the interview, PA school, nothing like that. Yes, you get into high acuity cases. Okay, I know you guys still have so many questions, but I'm going to move on to the case study. Like I said, feel free to email me if you have, you know, dire questions that really need to be answered. I don't mind. I'll put my email again. If you have specific questions, email me or DM me. You can talk about, like, I think I wouldn't even call or refer to ADHD or autism as a disability. It's an extra ability. Shine in your essay. Talk about how, yeah, I think you should tell them that, you know, this is what I was born with, but this is how far I've come with it, and this is why I'm going to be an asset in your program either way. So always think about your assets. What will you bring? Why will the program be better with you in it? Or why would the PA profession in general be better? So as an ERPA, I always discuss this in all my ER presentations because I want it to stick with you guys. Always be thinking worst first in the ER because it's the emergency room. So you want to think about emergent cases. Not every patient that you see will be an emergency, as actually most of them may not be emergencies in the sense that they'll, like, you know, it's not like life or death, or they're not going to die, of course, from it, or they'll be fine to go home. But always be thinking that. Make sure that whatever the patient comes in complaining of, that it's not something that's going to kill them. So make sure that the questions that you ask, the physical that you do, that you the notes that you take, all your documentation aligns with that, that you're supporting your case, that this patient is not, you know, severely ill or safe enough to go home, or this patient is ill and needs to be admitted. So that's all you're going to constantly be thinking. Worst first, what can kill your patient? Are they sick? Do they need to be admitted, or can they safely be discharged? What are some pearls? Remember, pearls are things that to remember about specific diseases or differentials or diagnoses, like like things that kind of align with those diagnoses. Like, well, you'll see some pearls today, so you'll understand more of what pearls mean. And you know, always be consulting your attending or supervising physician or a different specialist in the ER. So we're going to continue. Okay, so 42-year-old female with history of fibroids presents with complaint of right upper abdominal pain. You guys all see her vitals. I really wish somebody would come on the case study with me. It makes it so much more interactive and fun. Dang. Who wants to come on? I just feel like I'm talking to myself. Let's try Serena again. As I invite somebody, just be thinking about this presentation. As always, I like to support my objective findings with subjective presentations. So you see the patient's vitals, and then you see how the patient looks. The patient looks like she's in distress. She looks like she's obviously in pain. She's hunching over and kind of guarding, and she looks uncomfortable. So you know that, okay, she could be in abdominal pain for real. Okay, Eileen. Yes, thank you, Eileen. Hi.
Hi.
Okay, I can't see. I guess your video is not on. Or maybe it's...
Oh, I have one. Oh, there we go.
Hi.
Hello.
Thank you so much for coming on.
Awesome. Thank you for having me.
No problem. I'm pronouncing your name right, Eileen?
Correct. Yes.
Okay. Thank you so much. So you're a pre-PA?
Yep, applying this cycle. Well, when it opens
Yes.
for 2022.
Yes. Good luck. Good luck. Yes,
Thank you.
I'm ready to hear. I got into PA school.
Oh,
You
fingers
guys,
crossed, right?
yes. You guys, I want to have, okay, I'm not going to make, okay, I'm just a big mouth, but I want to have a virtual party. We're going to plan a virtual party for everybody that got into PA school, okay?
Yes.
We're going to do that, okay? We'll talk about it later. But you guys, you're my like little family, all 300 plus of you guys. But okay, so let's get into the case study. So Eileen, she's a 42-year-old female with history of fibroids. Serena was able to get in the chat too, because I just kept inviting people. So we might have like 5 people here.
Sweet, the more the better.
Yes. Okay, let's see if, okay, we're going to continue and then see if Serena's able to get her audio working. Hi, Serena.
Hi, can you hear me?
Yes, it's working now. Yes, you're a pre-PA as well?
Yes, I'm a sophomore in my undergrad.
Oh, you're a sophomore. Awesome. Okay, so you have a few years left.
Yes.
Okay. Alrighty, guys. So we're going to get into the case study. She's a 42-year-old female with history of fibroids who presents with complaint of right upper abdominal pain. So remember to always start by looking at your vital signs. Is there anything off with her vitals? Or do they all look
blood
okay?
pressure is running a little higher.
Yeah.
But it looks...
Yeah, the blood pressure is fine. In the ER, I mean, high blood pressure is like really anything over 140 over 90, or sometimes when it gets to the high 130s over 80s. But her blood pressure is fine, especially in the ER. In the ER, we don't even look at like blood pressure as being crazy until it gets to the like 190s or 200 sometimes. But yeah, her blood pressure is fine. Her vitals seem to be pretty good, stable. She's not even at a temp yet. Her temp is 99 Fahrenheit. So, her vitals look fine. But look at how she looks. She looks uncomfortable, right?
Definitely, yeah.
Yeah, like she's in actual pain. So when you walk into the room, you see her vitals, you see how she's looking. So you're like, okay, she could very well be in pain, or she is in pain. So what should you be thinking about with the right upper abdomen? Where specifically is going on in the abdomen?
Maybe her intestines?
Yeah, okay, I would think large intestine.
Okay, so with any abdominal pain, abdominal pain, there's so many organs, there's so much going on in the abdomen. It's not just the abdomen, it's also the pelvic organs. So a lot of the time, where the patient's having the pain can tell you a lot about what organ is being affected. So you have to think about what organs are in that area. So in the right upper abdomen, you have like your lower lung fields, you have your ribs, you have your liver, you have your gallbladder. You can have some intestines around there too, but really it's going to be your liver and gallbladder. Okay, and you can have a little piece of your pancreas too, but usually it's just going to be your liver and gallbladder. So that's what we usually think about in the right upper abdomen. So, and then when you see the patient, you're going to already be thinking about what are some specific things you want to ask the patient. So that's going to lead us into our history. So as I always say, you want to always make sure it's a focused history in the ER, because you have patients, it's the emergency room, things are going fast, so you can't be in that patient's room for too long, or you can't just turn it into like a long-winded thing. Remember that these patients are sick, so you want to be quick. So you only want to ask pertinent information, stuff really related to what's going on, okay? So as far as her pain, what would you want to know?
Maybe how long it's been going on, and is it consistent?
Okay,
and if she can point to where it actually hurts.
Exactly, yeah. So you'll want to know the onset. You want to know if anything makes it better or worse. The quality of the pain, is it a sharp, dull pain? If the pain radiates, like sometimes the pain can radiate to the back, the shoulders, the chest, wherever. The severity of the pain, when the pain came on, or has it been constant or comes and goes? Any associated symptoms. The associated symptoms leads us into the review of systems. So it's like other body systems that can be related to the pain, or other systems within that system, like other GI complaints that's associated with that. For instance, if she's having nausea, vomiting with it, diarrhea, fever, is she burning when she pees, does she have blood in the urine? Those are all symptoms, associated symptoms that you may ask that can help lead to the diagnosis or rule other things out. So then, of course, you'll want to know her past medical history. We said she had fibroids, but usually you're not going to think of fibroids, because fibroids is related to what? You know what organ is associated with fibroids? So fibroids are in the uterus.
I mean, your ovaries.
The uterus. So, and the uterus is lower. The uterus is a pelvic organ, and she's having right upper abdominal pain. So that's not really associated. That's just the history. So then you want to know surgical history. Knowing about past abdominal surgeries is really important with abdominal pain, because abdominal surgeries can put a patient at risk for a bowel obstruction, or other serious things going on with the abdomen. So it's important to ask surgical history, family history, and social history. A lot of times, as I've said in the past, these 4 things will already be in the chart. They'll already have been collected when the patient comes in, or the nurse may have gotten that information. Okay. I'm not going to say all these things the patient says. This is all really just teaching information. So the patient may say, oh, my pain started 2 days ago. It's been constant. It's worse when I eat. I'm having nausea, vomiting, diarrhea. I feel hot. So she's complaining of a subjective fever. Okay. So then you move on to your physical. So this woman's been having abdominal pain the past 2 days. It's been constant pain in the right upper abdomen with associated nausea, vomiting, diarrhea. So that's basically how you would present it. I have a 42-year-old female with history of fibroids coming in complaining of abdominal pain the past 2 days with associated nausea, vomiting, diarrhea. You can ask important questions like, she has no dark tarry stool, she has no bloody stool, she has no fever, even though she complains of a subjective fever. She does appear to be actually, we're going to get into the physical now. Okay, tell me if I'm going too fast or if I'm okay. Okay, so for the physical exam, it's going to be the same way. You want a focused physical. So you want to only look at pertinent information. So if she's having abdominal pain, you're not going to be looking at her feet or doing a musculoskeletal exam. You're only really going to be looking at the abdomen, or maybe like you do a GU exam, or not necessarily, may or may not do a pelvic exam depending on the complaint or what you find on the history. So GI is gastrointestinal. That's her complaint. So you're going to look at the abdomen and do, palpate. Palpate means to touch her abdomen. Make sure you go deep, really try to feel the pain. Make sure she's not having pain anywhere else other than the right upper abdomen. Also touch her bladder area, see if she has any suprapubic pain. You can touch her back around her kidneys to see if she has flank pain or CVA tenderness, which she doesn't. And then always do a heart and lungs exam. No matter what I do, unless somebody comes in with a sprain, I always do like a heart and lungs exam. It's just easy to listen to the heart and lungs, and it'll tell you a lot of things as well. And then, so when you palpate, you remember palpate means to touch. When you touch that area, she has pain when she takes a deep breath. That's an important part of the exam. So does anybody know what that's a sign of, what that's called? You guys don't have to know. I'm just wondering if you know. Anybody in the chat knows? Okay,
Could it be a problem with the diaphragm?
No, not necessarily. That's called a Murphy's sign. So it's typically a problem with the gallbladder. So when you press on their abdomen in the right upper area and you tell them to take a deep breath, if they take a deep breath and they say it's painful, that can be a sign of something going on with the gallbladder. And it's called Murphy's sign. Okay. That's just, you're going to have to know this as a PA. It's going to be on your boards and everything. So you may or may not remember it later on, but just letting you guys know. All right. So the next thing you want to know is, you get back to your seat, you go into the patient's room, you find all this information out, then you get back to your desk, and then now it's time to order stuff. So what do you want to order for this patient?
Definitely something for the pain, maybe a painkiller.
I'm sorry?
Definitely something for the pain, maybe a painkiller.
Yes, awesome. That's usually the first thing that I do. But usually, before I even order my labs, I'll order like some pain medicine or nausea medicine, or just something to relieve her symptoms. So for pain, sometimes you can do Toradol, but if it's like an abdominal pain, I try to hold back from Toradol. Toradol is a non-narcotic, so they like doing that in the ER. It's like a type of, it's an NSAID, like similar to ibuprofen, but it can be given IV. So Toradol, I don't like to give it with abdominal cases, just in case it's a surgical case. Excuse me, because there's a risk of bleeding with Toradol, or it can increase your chances of bleeding. So if it's surgical and then you go to the OR, you don't want to really give like things that can make them, bleed more. So I hold back from that. I like to give morphine, like low dose. I give like 1 or 2 milligrams IV. And then I give, with that, I give Zofran. Guys know what Zofran is? Zofran is for nausea, vomiting. You give like 4 milligrams. I give 4 milligrams IV, and I also give some fluids just to, hydrate them, especially if they've been vomiting. And then, now you go on, and then of course they're going to need an IV. All abdominal pain patients typically just get an IV as soon as they walk through the door, because they're going to need labs. They may need fluids and all of that. They may need a CAT scan with contrast, and you need an IV for contrast. Okay, so next you're going to order labs. So you're going to order a CBC, a CMP. Those are some basic labs. A lot of times you just order those. Lipase is an important lab you order for the abdomen. Anytime somebody has abdominal pain, it's good to order lipase. It's specific for pancreatitis. This may or may not be what the patient has going on, but if the lipase is high, then it could, something associated with the pancreas. So you always order lipase with your abdominal tests or abdominal complaints. A urine, always also order a urine, because a lot of abdominal pains is a UTI, or if not like a UTI, then like just something, or kidney stones, something going on with the kidney. So it'll help rule that in as well. And then what specifically for this patient that you want to make sure you have?
Maybe a CT scan?
No, as far as labs.
Oh, labs.
A urinary test? Did we say that yet?
Yeah, we are doing a urinary test, but it's a type of urinary test. But what's specific for her?
Maybe a pregnancy test?
Good. Yes. Remember, she's a female. She's 42 years old. She's complaining of abdominal pain. It could be a pregnancy. It could be an ectopic pregnancy. So you want to do a pregnancy test. So this is what the workup looks like. Somebody said, what's the workup in general? This is what a workup looks like. A workup is all the tests, labs that you can order. We haven't gone into imaging yet, but this is what the workup looks like for an abdominal pain. So one thing I want to point out is the CBC versus the BMP versus LFTs. So a CMP is a comprehensive metabolic panel. It's going to give you your electrolytes, and it's going to give you the liver function. It's not going to give you all the reviews of the liver function like the LFTs, but ordering a CMP is typically sufficient. As opposed to the BMP, the basic metabolic panel, that just gives you your electrolytes and your kidney function. It does not give you your liver function test. So sometimes some providers will order a BMP plus an LFT, or some will just do a whole CMP. Typically, I do a CMP because it gives both. It gives everything in one. It'll give you your liver function and your electrolytes and kidney function. Okay. CMP is comprehensive metabolic panel or complete metabolic panel. Just think of it as everything in one. Okay, So what imaging test is diagnostic? So what do you think is going on? Do you guys already have an idea of what could be going on with her? I mean, you guys don't have to, but at this point, as a provider, once you're a PA, you should have an idea of some differentials or what could be going on and what you need to order next.
I think a CT scan would be important now.
Okay, you can do a CT. Yeah, you can do a CT, but there's a specific exam that's diagnostic for this condition. So you can do something called an ultrasound of the gallbladder. If you can do like an ultrasound when you're pregnant, like a sonogram. It's basically the same thing except you're looking at the gallbladder and not the uterus. So, okay, ultrasounds are very tricky. I don't completely know how to read them, but they're very tricky. They're provider dependent, depending on who does them. The ultrasound tech is awesome at them. They can tell you exactly what's going on, but the radiologist ultimately reads them. So on this is a gallbladder ultrasound. This is the gallbladder, and then there's stones here, and then this is an ultrasound of cholecystitis. I'll further explain what you would see with that, but that's what's diagnostic of anything going on with the gallbladder or cholecystitis. So, do you guys know what the function of the gallbladder is?
To secrete bile?
Okay, I mean, it stores bile. Very good. So the liver creates the bile. The gallbladder stores bile. Do you know what bile is? It's like a reservoir, basically.
Yeah.
Do you know what bile is?
I remember it's like something, it's a mixture of like fats and other stuff, and like it's like kind of liquidy.
So yeah, well, bile is important for fat digestion. So the gallbladder stores it, and then when it's time to like digest it or do what it got to do, it releases it or whatever. But it's basically important for fat digestion. So that's why there's that's why there's these risk factors that causes cholecystitis that I'll go in further to explain. But yeah, so basically the liver makes it, gallbladder stores it, and then releases it when it's time for, all that digestion to go on. Okay, so these are, wait, I'm sorry. This is, okay, no, hold on. Skip that previous slide. I didn't get rid of it. Okay, so this is the patient's diagnosis. So she has acute cholecystitis. So this is another ultrasound, and this is what is diagnostic of cholecystitis. Okay, it's cholecystitis. Cholelithiasis means gallstones. Cholecystitis means inflammation of the gallbladder. Okay, so it's basically when a stone can obstruct the gallbladder, cause the gallbladder to inflame or the gallbladder wall to inflame, and then cause all these area of symptoms. And basically, the gallbladder needs to come out. So it's a surgical emergency. So on the ultrasound, you see, I don't know if you guys see the stone right here where my mouse is. You see a stone obstructing the gallbladder, so it can't do what it has to do. So it's going to cause that pain. And the gallbladder wall thickens. That's the normal gallbladder wall is 4 millimeters, but when it gets thicker, that means that it's inflamed. And then you'll have a positive sonographic Murphy sign. Remember what I said Murphy sign is? Well, what did I say Murphy sign is again, guys?
It's if you palpate and they inhale and it hurts, then it's a positive sign for a gallbladder pain.
Yes. Great. Yeah, so you palpate that right upper quadrant where the gallbladder is. Yes, great, Nicola. Great, guys. All right. So they have that Murphy sign when they palpate, when they press with the probe and do that ultrasound. And then with also gallbladder, you'll have abnormal LFTs or liver function tests. The gallbladder sits right below the liver. So anything that can affect the liver or that can affect the gallbladder can affect the liver because it has to release that bile to be stored in the gallbladder. So you'll see abnormal liver function tests. You'll also have your lab findings that can also be pointing to something going on with the gallbladder. So these are the patient's findings. And for cholecystitis, like I said, it's a surgical emergency. So you always admit these patients. There's no thinking, oh, should I admit this patient? Should I, can they go home? They're going to be admitted. And so that's why I really like abdominal complaints, because it gets pretty straightforward. You do a CAT scan or you do any imaging, find out what's going on, determine if they need to be admitted or not, or get surgery involved or whoever you need to get involved. And then that's it. So with cholecystitis, obviously, like it's something going on, something that's surgical, something that infectious or can become infectious, then you need to start antibiotics. Okay, and you want to start broad spectrum antibiotics. Broad spectrum means that they can target many different bacteria going on. So, and you want to cover anaerobes. Anaerobes affect the GI tract. So anaerobes can be antibiotics such as Zosyn. I mean, you guys of course, I don't expect you to know all this right now. So Zosyn is a good antibiotic, or Cipro and Flagyl. But either way, you're starting antibiotics. The patient is you're gonna consult surgery. And then what are you going to tell this patient that the patient cannot do?
I feel like eating or drinking.
I'm sorry?
Eating or drinking?
Perfect. Yes. Don't eat. NPO. So the patient's going to be NPO. So nothing by mouth, okay? And then somebody said to point to where the stone is. You see you guys can't see my mouse. Okay, the gallbladder is that hollow, that black area. And then you see like a circle thing, like at the end of the black thing. That's the large stone. So you see the gallbladder, you see the black area to the top right. And then you see the stone at the bottom. Okay, yes, so they can't eat or drink. But now you need to order more labs. What labs? I see some people already said it. What labs do you want to order? Since the patient's going to go into surgery.
I'm not sure. Another blood test? Oh, we already did a blood test.
Yes, platelets. You want to order not platelets. You want to order bleeding times. So platelets is important. So platelets will be in your CBC, but you want to know their bleeding times, because if they're on like anticoagulants that can make them prone to bleed or decrease their bleeding times, then you want to know of that. That's important to know their bleeding times, and that's going to be in the PTT, PTINR, and you want, of course, you may want to know their blood type, in case they need blood during surgery. So those are some extra labs that you may order. You may not even necessarily order them. The surgeon may order them, but usually I add on those like PTT, PTINR, and maybe a type and screen. Good job, guys. Okay. So we went over the gallbladder. The gallbladder sits on top of the liver, and sits below the liver, right below the liver. The gallbladder stores bile. The liver creates bile. The gallbladder stores it. But when you have you can form gallstones, and the gallstones can obstruct that the release of the bile and cause inflammation of the gallbladder, which leads to cholecystitis. So risk factors for cholecystitis is literally this. I am not being offensive to anybody. It's we learned this in PA school, and you will hear this: fat, female, 40, fertile. So those are all risk factors for. Remember, think of fat as in like fat digestion. So fat, female, 40, fertile. And so usually if you see a patient with that presentation too, you'll think that, they could have cholecystitis. And a lot of times patients will say it's worse when they eat fatty meals or greasy foods. So think of that too. And then they'll have right upper quadrant pain. The pain will be worse after fatty meals. They may have fever. They may have nausea, vomiting. And it'll be general surgery. General surgery does gallbladder removals, appendectomies. The most common surgeries are appendectomies and gallbladder removals. And they're they're fairly easy, quick surgeries. Sometimes patients, I think I've seen patients do it and they may have like one night hospital stay, or they may be out. Have I seen an outpatient one? I don't know, maybe it varies, but it's a fairly relatively, straightforward procedure. And a lot of them are laparoscopically done, which means they just form little holes in your abdomen. They don't have to like fully cut you or anything. You have minimal scarring. So that is the gallbladder. And as I always, yes, cholecystectomy is removal of the gallbladder. They take out the whole gallbladder. And as I always tell all of you, of course you don't know this now, but as you're learning, know what's common, know what you'll commonly see, not just in the ER, but as a PA in general. Know zebras, know things that you may never see in your life, but that you got to know at least a little bit about it, and know what can kill you. Know what can kill your patient, recognize it, know when to refer them to the ER, know when to keep them in the hospital just to make sure that doesn't happen. And those are just the facts of life. And of course, as I always say, document. Make sure you dot your I's, cross your T's, make sure your documentation's stellar. And that is it. Zebras are basically what you may never see in your career, but you'll need to know. Somebody asked what zebras are. You will remove the entire gallbladder. Okay. So do you guys have any questions about the case study?
Yeah, so how would you, what would the patient's diet be like now once their gallbladder is removed? How would you kind of guide them into changing their lifestyle?
So I've heard that. I mean, a lot of times they can, as far as go back to eating like certain foods, some patients do report that, they're not able to eat certain foods. But I think for the most part, of course, after any surgery, you're not going to go right back to eating. You're going to slowly advance. But they'll have that conversation with their surgeon. I can't say for sure, because I'm no longer there at that point. But for the most part, I think they're fine with going back to, their regular diets, or they may not be able to eat they'll say after getting their gallbladder taken out that they can no longer tolerate maybe fatty meals anymore. But they'll have that conversation with their surgeon. But I think that usually they're fine.
What if they put off the coming into the ER and it got progressively worse? What
if they cut what?
If they delayed coming into the ER and it got much, much worse, would the whole gallbladder need to be removed, or what would have happened?
Well, the whole gallbladder is removed. You take out when you do a cholecystectomy, that's what you do. You take out that pouch, that gallbladder. It's a tiny pouch, but the whole thing comes out. But if they delay surgery, and they're at risk of having a big infection, a bad infection, sometimes they can have a whole infection of that. There's the biliary tree where the passageway and all that of just the anatomy, but you can have an infection of the biliary tree, which is really, really bad. But if they prolong it, it can turn into bad stuff. But yeah, either way, you're gonna have to have your gallbladder removed. It's just making sure that you don't have a crazy infection, or the surgery is not a really bad or difficult surgery. Yeah, they don't ever remove a piece
so
of
if
gallbladder. They'll always remove the whole thing.
So piggybacking off of that question, let's say they did, and they did get an infection, would that then go to the liver, or would it be, where would the infection travel to usually?
Well, the infection can be like in your whole abdomen. It can affect your it can become like a whole abdominal infection, but it'll usually affect like the biliary tree, like the common bile, like all the ducts associated with the gallbladder. I wish I uploaded a picture of the. I wish I uploaded a picture of that anatomy, but there's ducts and everything associated with the gallbladder. And it can lead to, people also said sepsis. It can lead to sepsis, which is like a really bad infection. I think I talked about this a little bit in the last week's segment, but that's a really bad infection that your body has a hard time of fighting off infection, and it can lead to bacteremia, which is an infection in the blood, in your bloodstream. So you definitely want to prevent all that.
I remember in one of the slides, it talks about the patient being positive for COVID.
Oh no, that disregard.
Okay.
I remember. I forgot to take that slide. I'm sorry. I forgot to take that slide off. That was from another presentation.
I was like trying to remember which slide it was. I was like, what if it's the slide that she skipped? But I was like, I'll ask anyway.
Oh, you can ask. No, but that was another presentation. But I mean, the patient will need a COVID test. Actually, every patient that's admitted to the hospital now needs a COVID test.
Mm-hmm. How would you anticipate her being positive for COVID? How do you think that it would definitely impact the pain more, because the acute, I don't know how to pronounce the other word. It's when you feel pain, like when you're breathing. So do you think that maybe COVID could have like an effect on the pain, make the pain worse, or make the pain be felt in a different place?
Well, actually, I actually did have a patient with COVID and with cholecystitis, but she did not have any COVID symptoms. It was just an incidental finding when we tested her. She was diagnosed with cholecystitis, and then we had to test her for COVID because she was admitted and going to need surgery, and she was found to be positive. But she didn't have any symptoms. But having a COVID diagnosis and having symptoms with that, a lot of times it's hard to have two diagnoses or two completely different diagnoses and to have like symptoms at once. I mean, of course, having COVID and having cholecystitis is both bad. But and of course, especially if the breathing component is affected, that's going to be terrible. And you would have to prioritize on which is important to treat at that moment. So if her breathing is really, really bad and she's going to need, and it's very low for these, two bad things to happen at once, as I was saying. So say she's really, her breathing is really bad. She needs to be on a ventilator, and then she has cholecystitis. There's a low chance of it being that bad. But if that's what you're asking, then the surgeon and the ICU team or intensivist, they would have to coordinate on what they would do. So yeah, I hope that would never be the case. I've never seen anything like that. And at that point, the ER team would not necessarily, the patient would then have to be admitted, but it's a conversation for other specialists.
Got it. Thanks.
Did I answer that? Or that was
No, you definitely did.
Okay. Okie dokie. Do you guys have any more questions?
No, that's
it. I think that's it. Yeah. Thank you.
Okay. Well, I hope you guys like this case study.
Definitely.
A lot of what I explained is just to the confines of the emergency room. There's a lot more, of course, that goes on once the patient gets admitted and goes into surgery. And then, that's all that goes into the general surgery component. But yeah, so that's about it. I know we went over a little bit, but I wanted to get through this case study. I'm glad. I hope you guys learned something today and enjoyed it.
Yeah.
Yes, absolutely.
Thank you so much, Eileen and Serena.
Thank you.
Thank you, guys. Do you guys have any other general questions?
Of course, the one time I have an opportunity to ask a question, my mind goes blank, but I'll definitely reach out if I do.
No problem, guys.